work the way I want them to. Right now, they're doing something weird though. So let me try, let's see here. Sorry about this, guys. Usually I'm a little better with technology than what I'm experiencing at this moment.
If you want me to, I can share my screen.
That would be awesome, because clearly I'm having one of those moments.
That's okay.
I would love to say doesn't happen to me often, but that would be a lie.
Well, when you're not used to the program, it does take a little bit.
When I teach at Viterbo, thankfully, a lot of the students that I have there are much better at technology than what I am. So I'm frequently asking my students for assistance.
Problem. I just gotta. All right. Can you see it, Mandy?
Yes, I can. Awesome. I wonder, am I able to control it though, or are you?
I will probably have to control it, so I'll just kind of keep up if
Okay.
I can here.
So I just switched it. Did you guys see, do you now see the screen that says diagnostic criteria for a substance use disorder?
There you go.
Okay. Perfect. So before I get going on anything related to MAT, I just really wanted to provide, and those of you that are trained in treating substance use disorders, I'm sure you're very familiar with this, but I just wanted to start with kind of that basic foundation of this is the diagnostic, the DSM-5 criteria for a substance use disorder. So just certainly wanted to give that overview before I jump into this, because here at Gundersen, you know, and really anywhere, before we entertain the idea of offering medication-assisted treatment, whether it be Vivitrol for alcohol, methadone, or Suboxone for opiates, we really need to do a full screening and assessment just to get an idea of that individual substance use history. And part of that substance use history is also gaining an idea of how long they've been using substances, if they've been on MAT in the past, if they have been on MAT in the past, how has that gone? Were they successful? Our nursing staff, we have a pretty large team at Gundersen. We have about 30 duly credentialed providers that are licensed in mental health and substance use disorders. And the vast majority of those providers are also a part of our medication-assisted treatment program. We have 3 addictionologists. We have about 10 nurses and MAs, and all of us really work together to support this MAT program. So when a referral comes in for MAT services, they're first screened by our nurses, just to get an idea of, do they meet criteria for our program? Do they have a substance use disorder? And then the patient will be seen by one of the master's level therapists to gain clarification about additional symptoms. Have they been a part of MAT before? And if they have been part of MAT before, we work to get those records. A lot of the folks that we work with have received medication-assisted treatment outside of Gundersen, like with AMS or someplace like in Eau Claire or Rochester, a variety of places, because we really want to get an idea of, is this person going to be successful in our program? And if they've had struggles in the past, we want to be aware of that from the get-go so we know where to support them. One thing that we really pay close attention to is diversion. If someone has been on medication-assisted treatment in the past, we're hesitant, not to say that we won't, but we're hesitant to take on folks that have, you know, been involved in diversion, selling their medication on the street, because unfortunately there's a pretty significant street value to methadone, to Suboxone. So that's not something that we want to support in any of our communities, having that out on the street. So again, just kind of getting back to this first slide, it's, you know, a therapist, master's level therapist, or even our physicians meet with the patient and really gain that clarification of what their substance use history has looked like. I'm sure many of you that work in the field of substance use, it's rarely one substance. Usually it's a lot of different substances. More so lately, we've seen a spike in methamphetamine use, also with alcohol. For a while there, it seemed like the majority of referrals that we're getting in were for opioid use disorder, but it seems like there's definitely been an uptick with methamphetamine, along with opiates, alcohol, and it seems like there's always been that underlying kind of use of cannabis with a variety of other substances. With our Suboxone program, we're a little bit more lenient with people that are on the Suboxone program and occasionally use cannabis. When it comes to our methadone program, because methadone is federally regulated, there's really stringent guidelines about that. So if someone is receiving methadone and is using other substances, they can be discharged from that methadone program, or it can be a situation where they won't receive take homes or their dose won't be increased. So it's really looked at as a case by case scenario. But with both programs, we really try to, support the patient in abstinence, complete abstinence. We realize though that we have to meet the patient where they're at, because we've learned that putting the cart before the horse and demanding complete abstinence from the front end can sometimes cause us to lose folks, that could be successful if we allowed some leniency on the front end. But we certainly don't want to give the message that it's fine to be on medication-assisted treatment and continue to use illicit substances. So there's certainly interventions that we invoke to really help support their sobriety. Any questions about this first page, just about substance use disorders and assessing? And like I said, you can certainly ask questions as we go along. And then did it switch for you all when I clicked to the next one? To the introduction page?
I switched it.
Oh, you did? Okay.
Yep.
Okay, so I'll just indicate to you then, Christy, to go to the next slide. Okay, perfect. Got it. So just an intro to medication-assisted treatment. And for those of you that are familiar with it, this is going to be redundant, but for those of you that aren't, just a high-level overview. So medication-assisted treatment is a combination, and I cannot emphasize this enough. It's not a standalone. It's not like giving someone penicillin for an infection. It's something that it's an intervention that needs to be included with therapy services. So if someone is receiving medication-assisted treatment, they're not just receiving that medication and told, go forth and prosper, see you in 6 months for a med check. They're very much involved in therapy services, even if someone has had therapy in the past. So with our methadone program, they're required to be involved in therapy services for the duration of their involvement with that methadone program. So I have a patient that I see that's been on our methadone program for probably 15 years. And not that I have to see him on a weekly basis. I see him about once every 90 days. However, he has to remain involved in therapy services for the duration of that, because not only is it federally regulated and federally mandated, but just our philosophy is that if someone's on this type of medication, they still need that recovery support. It may not be as often as what they needed initially when they were inducted into the program, but they still need that support for their recovery. So again, just to kind of emphasize that first point on here is that we definitely have that multimodal approach. And it's not just a Gunderson thing. It's, across the board, if you were to reach out to any of the opioid use disorder programs for methadone or Suboxone, there really is that emphasis about the need to have medication along with psychotherapy. And the psychotherapy can be in the form of individual therapy, it can be group therapy, it can be residential treatment. We have residential treatment services that even, if you're in residential, you can still receive your dosage of methadone or Suboxone. I realize that's not always the case in every residential program, but we really want that partnership to be there, that no matter what care you're in, you can still receive your medication. So medication-assisted treatment is approved and regulated by the FDA. They're clinically driven, and we really tailor each individual program for that individual, because when we get someone in, there can be housing insecurity, food insecurity, childcare issues. So it's not as if we give them the medication and send them out the door. We really look at that individual as a whole person, because we realize that if they're only getting the medication and they don't have other things that are being addressed, they're way less likely to be successful. So we have an addiction med social worker that provides resources, supports them, connects with them, really to support that therapy involvement. So moving to the next one, the MAT is primarily used for alcohol use disorder. So that would be the Vivitrol or the Campril. And then for opioid, we have Suboxone or Subutex, and then methadone. Both programs, are regulated. Like I said, more so methadone is regulated by federal guidelines. However, there is a change that's going to be coming for Wisconsin, for Wisconsin DHS 75, that oversees and regulates, is the regulatory body for medication-assisted treatment. So the guidelines that are currently in place for methadone are actually going to now be coming into play for Suboxone programming as well. So there's going to be a little bit more stringent oversight for our Suboxone program, which I personally think is good, because there's going to be more requirements as far as therapy, as far as oversight, required urine drug screens, required film counts or pill counts. So I just think like that change that's going to be coming up will be really helpful, because I'm someone that doesn't do great with gray. So I like what I can do, what I cannot do, what I need to hold my clients accountable for. So I look forward to actually those changes coming up. You can go to the next slide, Christy.
Hopefully it's working. I'm having some technical difficulties. Can anybody just let me know if they can't see it?
The next one should be the goal of MAT.
Oh, yep. The philosophy.
Let me do. It should be, I believe it's right before then. Yep, there we go. Yeah. So just wanted to provide an overview of the goal of MAT, because for those that aren't familiar, I know when I came to Gundersen, I worked at Mayo and we had Suboxone there, and I was familiar with that and how it worked and why it worked and really the goal of it. There was definitely a learning curve though when I came to Gundersen, because I wasn't familiar with methadone. So it really helped to gain an overview of what we really look to achieve for MAT. So of course, the first and foremost is to improve patient survival, because we know that helping someone, get off of an opioid is really, really difficult. Not to say that it can't be done without MAT. It certainly can. There's plenty of folks out there that got into recovery without MAT. But we know statistically that folks do better when they have that support, when they have that basis to kind of build upon. And so the goal of MAT is to improve that patient survival, to reduce the amounts of overdoses. The other piece is to increase retention and treatment. So I know when I was facilitating an AODA day treatment, it was easier for me as a clinician to engage people in recovery, in topics of recovery, if they weren't experiencing significant withdrawal symptoms, if they didn't have significant urges and cravings. So I know as far as retention and treatment in comparison to without MAT, I've seen a significant difference. And again, I don't want to send the message that you can't get into recovery and be successful unless you're on MAT, because that's absolutely not true. It's different for everyone. But I know that MAT can certainly be really helpful to support folks in recovery. The other piece is it decreases illicit opioid use and other criminal activity that people with substance use disorders often experience. Because they're receiving a medication, there isn't that need to still connect with those, folks that are still using, to go on buys, to struggle with being able to afford their substance use, because medication assisted treatment is covered by insurance. So it really takes that person out of that criminal activity. Did someone have a question? Okay. The next piece is increasing patients' ability to gain and maintain employment. Because I know for me, when I'm working with someone that is newly in recovery, there's struggles with getting up on time, getting to work on time, motivation, having urges, cravings, being on binges where they've used and they can't just make it to work. They can't be able to maintain that job. And so being on MAT can really help obtain and maintain employment for folks. The other piece is that, so for folks that are women that are pregnant, it definitely improves birth outcomes. We have a physician that's part of our addictionologist team, and for probably the past 30 years, his name is Dr. Schauberger. He is an OBGYN physician. And so he's an integral part of our team, because not only does he have the background training specialty in working with pregnant women, he also has that training in working with substance use disorders. So he can hands down say this makes a significant difference in women that are pregnant to get into recovery, stay in recovery, and also maintain custody of their children after they deliver. Because that's frequently a common concern, that when, a mom is using during pregnancy, CPS is involved, and on some occasions, the children are removed because of that. So getting someone involved in MAT really helps support, mom's ability to be able to keep that child with her versus being in placement somewhere else. And then the last piece on here is research has shown that MAT and therapy can contribute to lowering a person's risk of contracting HIV and hepatitis B or hepatitis C, I'm sorry, by reducing potential for relapse. So again, it takes that person out of that using realm where they're injecting, where they're staying in trap houses. I realize that that's a slang term, but it's very legit. So it takes them out of those really scary situations and allows them to be in stable home environments. You can go to the next slide. Did it work for you, Christy?
Yep.
Okay, awesome. So this is an overview of our program philosophy, and it's very similar to other program philosophies. So if you look at any MAT program really across the globe, it's probably very similar to this. So our approach is definitely multidisciplinary and holistic. Like I said, we have MAs, we have RNs, we have our addictionologists. We also, though, have access to family med physicians, to dietitians, to social workers. And I know with Hiawatha Valley, there's definitely a plethora, even in Winona County in general, there's a plethora of services. So using that multidisciplinary holistic approach is the best thing for your folks, because it's that Maslow's hierarchy of needs. We need all those things to function as a human being. And it's difficult, if not impossible, to get into recovery if you don't have your basic needs met. So housing, food, gas to get into treatment, childcare, things like that. Those are all things that we look at when we're bringing someone into a MAT program. And of course, the goal is to provide the best possible treatment, the individualized treatment. So of course, when we do treatment plans, it's what does that individual need to support their recovery? I mean, of course, it's, maintaining freedom from addiction. It's also, though, addressing mental health diagnoses. If there's physical ailments, a lot of times when folks are inducted into MAT, there can be a variety of health concerns that are going on. There can be sepsis, there can be infections. So just making sure that we're addressing all things that are going on with that individual as well as their family, because addiction is a family disease. It's not something that just impacts the one individual that's using, it impacts everyone around them. So with the office-based opioid treatment, which is buprenorphine, and then the opioid treatment program, which is methadone, we offer, so with Gunderson, we offer detox. More often than not, though, it feels lately we've been using places like Chippewa Falls for detox. And I realize that's not the best case scenario. We're hoping to make some improvements with that, but that definitely is part of our program, is sending someone for detox if they need it. That usually is in the case of alcohol use disorders that we send someone for detox. We can usually manage someone with an opioid use disorder within Gunderson, for that detox for opioids. And then we get them connected with an individual therapist. And we also strongly encourage 12-step meetings. And I know in Winona County, there's a great group. There's actually a variety of groups for 12-step recovery and things like that. So again, it's not a requirement to have 12-step involvement, but we strongly encourage it for those that are interested in it. And then we actively treat comorbid drug utilizing as an evidence-based approach in conjunction with specialized individual and group psychotherapy and education. And actually, we have our nurses come in and provide education. Our addictionologists actually run a couple groups. They do a psychoeducation group talking about recovery, talking about the biological impact about substance use. So we try to infuse a variety of services to support our patients. And then, of course, folks that have psychiatric conditions, getting them in with a psychiatrist or a nurse prescriber is key as well. So just making sure that they have that support. And then as part of the MAT programming, a large emphasis is placed on monitoring. So folks that are on our methadone program, when they first begin, they daily dose. Because it's just, again, with the federally regulated programming, it isn't something where you can get take-home doses right away. So when someone is first initiated on MAT for methadone, they come into the clinic on a daily basis. Our clinic is open from 7 a.m. to 10 a.m. So folks come in every day to dose. And then once they get take-homes, they can have additional bottles to go. And then after they've utilized those bottles, they bring those empty bottles back to the clinic then. It's just a way for us to kind of keep that balance of managing diversion, making sure that people are taking their medications as they need to. So it's basically a safety measure. You can go to the next slide.
Okay.
And I'm hoping you guys see who can prescribe buprenorphine as the next one.
Yep.
Okay, awesome. So just to give an overview, and I'm sorry again if some of you are familiar with this, but just wanted to provide a general overview for who can prescribe buprenorphine. So it certainly can be a physician in family medicine, it can be a nurse practitioner, it can be a physician assistant. For the longest time, it was just physicians, but there's been some regulations that have passed that now allow nurse practitioners and physician assistants to be able to prescribe. So for physicians, it's an 8-hour training, and then for nurse practitioners and physician assistants, it's a 24-hour training. The vast majority of folks that do that training, there still is kind of like a mentorship kind of program that goes along with it, because there are so many different variables that go along with prescribing buprenorphine. And supporting that patient and just knowing the ins and outs of that it's not as if someone does the 8-hour training and they're like, I'm good to go, let's bring on 100 patients. There's a lot of support that goes into that. And of course, clinicians can take on 100 patients right away. Really, though, we encourage them to take it slow just so they have that support and can feel comfortable providing that treatment for those folks. So within our organization, we have 3 addictionologists. We're also, though, expanding to our family medicine clinic and our internal medicine clinic. So how we do things is that we will do an induction with someone for Suboxone and behavioral health. And then once they're stable, and by stable, I mean they've been on the program for about a year, then we can offload them to their family medicine physician, as long as that family medicine physician has had the training. So that allows the patient to then solely follow up with their family med physician versus having a family med physician and then also someone in behavioral health that they have to see. So we definitely have that partnership to meet the client where they're at. And if it's more conducive for them to stay in behavioral health, they're welcome to do that. But if their preference is to see their primary care provider for everything, they certainly can do that as well. So this just gives an overview of the ins and outs for prescribers. I don't want to insult anyone's intelligence. I know you all can read that, so I'll let you read that either right now if you'd like, or once Christy gets the PowerPoint out to you all, but it just gives an overview, and I don't think we have any prescribers in this group. Is that accurate, Christy?
Correct.
Okay, got it. So you can go to the next slide then. There we go. So for the methadone program, so as I had said before, the methadone program is more heavily regulated in comparison to the Suboxone or buprenorphine program. There are federal guidelines that oversee this, and it's very prescriptive as to how much you can start someone out, a patient out for medication and dosing, how many take-homes they can receive, how frequently they need to come in for urine drug screens. In addition, so with the methadone program, there's an oversight for the state of Wisconsin, and Minnesota has one as well. It's called a SOTA, so a State Opioid Treatment Authority, and it's one individual. An individual oversees Minnesota, a different individual oversees Wisconsin. For ours in Wisconsin, it's Beth Collier, and she oversees our methadone program. So once a year, she comes and reviews our program. She'll observe dosing. She'll review with me our training for our clinicians, making sure that they understand the requirements for programming. She'll interview a couple of our patients just to get an idea of how they're doing in programming. We'll get ideas from her on to, what she's learned with visiting other clinics on how we can improve our program. So again, with methadone, the physician has to go through training, and for methadone to be prescribed for medication-assisted treatment, so for opioid use disorders, it needs to be part of a methadone clinic. And the reason why I emphasize that is, so any physician can prescribe methadone after they've done the training. They can only prescribe, though, like in a family medicine clinic, if it's for pain management, because methadone can be prescribed for pain management as well as medication-assisted treatment to help someone get into recovery. In order for someone to be prescribed methadone for medication-assisted treatment, it needs to be within a methadone clinic. So with that too, with our methadone clinic, our physicians cannot prescribe methadone for pain management specifically. So if someone comes in with an opioid use disorder and also has chronic pain, we can prescribe for that. However, if someone comes in and has chronic pain, is requesting methadone for pain management, we can't offer that within our methadone clinic because that's outside of the federal rules and regulations. They can be referred to their family physician to inquire about methadone. However, it can't be prescribed solely for pain management within our methadone clinic. Any questions with that? I know that can be kind of wonky. All right, you can go to the next one then.
Great.
So withdrawal symptoms, I wanted to provide this overview of withdrawal symptoms because with both buprenorphine and methadone, these medications aren't started until the individual is experiencing withdrawal symptoms. So if someone comes in who is under the influence of opioids, if someone comes in under, we've had folks that they haven't used opioids for probably a week, but they come in intoxicated under some other substance. We cannot do an induction if someone comes in under the influence of illicit substances or alcohol. So that's certainly something before we give someone their first dose. We do a urine drug screen, we do a breathalyzer test just to make sure that they're not under the influence of other substances. Of course, if someone's in withdrawal, that's one thing, but we had someone not so long ago that came in that hadn't used opioids but was intoxicated with alcohol. So that was something that we couldn't, they were using alcohol to kind of stave off the withdrawal symptoms from the opioids, which that then impacted their ability to start on the methadone. So I just wanted to give this overview of withdrawal symptoms. So with alcohol, before we start Vivitrol or Campril, we look at these symptoms, we assess. And of course, with alcohol, we really need to be mindful of, has that person had significant withdrawal symptoms in the past? Have they experienced seizure? Have they had experience with withdrawals in the past? Because I know as a clinician, I've done an intake assessment and I'll ask, what's the longest period you've gone without drinking? And some folks will say never. I haven't ever had an episode where I've gone since I started drinking at, I don't know, I'll say 25 and they're 45, they'll say, for the last 20 years, I haven't had any period of abstinence. With someone like that, I'm definitely going to want to monitor them and likely will refer them to detox because I want to err on that side of caution. I worry about their withdrawal symptoms because with alcohol withdrawal, someone can experience a seizure and die. So we're really cautious with folks that are alcohol use disorder severe because we want to be mindful of that. So with the alcohol, we assess with that, and then we can give them the Campril, the Vivitrol injection once they're in withdrawal. The Vivitrol injection is usually in the buttocks area. I haven't seen the needle, but I'm told by patients that it's a rather large needle. So when I have patients that are going in for the Vivitrol injection, I'll say, you might want to just look the other direction as you're getting the injection because it's kind of large from what I've been told. And then there is some soreness afterwards. In comparison to the Campril, Campril is a pill, actually 3 pills that you take 3 times a day. Campril can work really well. I've been told that there's some digestive issues that can happen with Campril. So for the folks that I work with, a lot of them default to Vivitrol because it's 1 injection, 1 time a month versus taking multiple pills each day. And there isn't that abdominal discomfort like there is with Campril. The folks that I've had say no thank you to the Vivitrol are generally the ones that are kind of worried about the injection piece. So it's just, I personally think that Vivitrol is a better option for the majority of folks because you're not having to remember those pills each day. It just stays more consistent in someone's body. With opioids, then similar. When we do the intake assessment, we get a substance use history and then they meet with a physician to really gain an understanding of, is this person currently in withdrawal? If they're not currently in withdrawal and we start something like Suboxone specifically, it's going to put them in precipitated withdrawal. So if they're still actively under the influence and we give them buprenorphine, it's going to basically, think of a bucket and you dump that bucket out and nothing is in there. And nothing being in there is going to cause them to feel really bad. So we encourage folks, please be honest with us, because if you've used within the last 24 to 72 hours, and you don't tell us that, and we give you buprenorphine, you're gonna not feel good at all. So usually by saying that, folks are then honest saying, well, yeah, I did use 24 hours ago or just before I came. because we want to set folks up for success. We don't want to give them buprenorphine and have them feel miserable. The thing is, though, is that folks need to be in withdrawal slightly. It doesn't have to be full-blown withdrawal, but experiencing some of these symptoms before we administer any type of MAT. Like I said, again, especially for the opioids, because if we give them buprenorphine and they've just recently used, they're going to feel really bad really quick. So, and some folks learn the hard way. We've had folks that say, no, I haven't used for 72 hours, and they used recently and we dosed them and they immediately feel very sick. You can go to the next slide. So the types of medication-assisted treatment, just to give an overview. So some of these I've talked about already. So acamprosate, which is also known as Campril, that's the pill form. Disulfiram is Antabuse. Antabuse has been around for eons. That is the medication that you take on a daily basis, and if you drink, you get violently ill. I have to say, though, I've had my fair share of clients that have been on Antabuse, and they take the Antabuse and get violently sick and then just continue on drinking. I've had some folks that will say they're taking the Antabuse, not take the Antabuse and continue to use. So I don't, at least from my perspective, I don't feel like Antabuse is used that often anymore, just because we have other medications that are a little bit more effective. So the naltrexone, otherwise known as Revia or Vivitrol, and those are the injections that I had talked about. So those ones are given to stave off urges, cravings. I've had folks throughout the years that have said, you know, without Vivitrol, I don't think I would have been able to get in and maintain recovery. It just helps stave off that urge, that craving. If someone were to drink on that medication, it doesn't have the same sort of response, or you wouldn't have the same sort of response as Antabuse. You won't get violently ill. However, it kind of numbs, for lack of a better way to describe it, the euphoric effect of alcohol. So that's something that I really work on the front end to educate folks about, that, you know, this is meant to really manage your urges and cravings to help reduce them. It's not going to make you violently ill if you do drink. It's not going to be rewarding, though, if you do drink. And that's really what we're looking at achieving, because obviously we drink and use substances for a reason. So just putting that out there to clients, saying, you know, you may drink on this, however, it's going to impact the euphoric or good feelings that you get when you do drink. And then for opioid use disorders, we have buprenorphine, Suboxone, and then there's also a Sublocade injection, and that's a one-time injection. There also recently came to the market a patch that folks can wear that is for opioid use disorders. And then there's also methadone and naltrexone. So with naltrexone, that can be used for alcohol and opioid use disorders. I would say for the most part, with folks with opioid use disorders, we rely on buprenorphine and methadone. Our buprenorphine program right now has about 165 patients, and our methadone program right now is capped at 50. And the reason why our program is capped at 50 is just our dosing office isn't that large. There could be some point in the future where we do expand, and we can expand then our services. In comparison, if anyone's familiar with Addiction Medical Solutions in Alaska, I believe I talked with Charles, who is the owner of Addiction Med, and I believe she has upwards between like 400 and 500 patients at AMS. So just to kind of give that comparison of, you know, we have a cap of 50 at Gunderson, and at AMS they can have hundreds of patients that they're seeing. So getting back to this then, so when MAT is used for substance use disorders or for opioid use disorders, it definitely addresses that urge and craving for opioids. Also, though, I want to just call out, so buprenorphine or Suboxone is a partial opioid agonist. So it does not produce that euphoric kind of effect that folks can get from opioids or even from methadone. So it staves that euphoria off, and it also helps manage those withdrawal symptoms. Whereas methadone, in comparison, is a full opioid agonist. So again, if you think back to that bucket, I like to use kind of metaphors, and I'm a visual person. So think to that bucket. If that bucket is empty, methadone, we put that in and envision methadone to be like cement. So if someone uses an opioid on top of using methadone, they're not going to receive that benefit of using an opioid. They're basically throwing their money out the window because it's not going to do anything, because that opioid receptor is filled with cement, we'll say. So anything used on top of that is just going to fall off that opioid receptor site. It's not going to do anything for folks. Just knowing that piece for a lot of folks really helps too. It can really help with those urges and cravings because, you know, they can visualize. I will literally draw it out like on a dry erase board. Like, this is your opioid receptor. This is what it looks like with methadone. If you use on top of that, it's just going to spill over. There isn't going to be any benefit to that. And then lastly, naltrexone then blocks the effects of opioid medication. So it's that combination. And then naloxone. I'm sure the majority of you have heard of Narcan. So Narcan is now something that our law enforcement carries, our EMTs. We have it in our residential treatment facilities. We have it in the crash carts on our units. When our addictionologist first came to us, she came from a facility down in Florida, and they actually had it in their offices, like the prescribers had it in their offices. So it's something that a lot of us that work in the field want and need to have access to. I know here in La Crosse, it's given out, you know, with, I believe it's the AIDS Resource Center, which I think goes by a different name now, but it's offered in a variety of venues. And as part of when someone is initiated into our methadone and buprenorphine program, the physicians automatically offer a prescription for Narcan if they don't already have access, because it's something that we just feel strongly that all of our folks need to have access to. You can go on to the next one. So then this next slide is just MAT initiation and dosing. And I don't mean to get too far into the weeds with this, but I just wanted to give a general overview because I feel like this is just a helpful kind of oversight of this is what it looks like. This is what the dosing is. So with Campril, I had mentioned that it's 3 pills per day, and they're 666 milligrams. So you're ingesting quite a bit, and there can be that abdominal discomfort going along with Campril. So with that, it can be, you know, someone can initiate this within 5 days of their last drink. If someone, the piece that I want to call out about this, so if someone isn't fully invested in recovery, the likelihood of Campril being helpful is definitely lessened. So if someone is still actively using, is on the fence about getting into recovery, you know, if we assess that motivation for change and they're pre-contemplative or even maybe contemplative, Campril may not be the best medication to offer them. Because studies have shown that Campril is something that works best when someone has made that commitment to recovery. Again, it certainly feels like with taking Campril, you're not going to experience those negative side effects like you would with Antabuse. It helps with urges and cravings, but not to the degree where if you don't have that motivation already there as the foundation, it's not all that helpful. So just throwing that little tidbit out there. And then Antabuse, kind of gave that overview of the Antabuse. So if someone does drink on Antabuse, they will pretty near immediately feel really uncomfortable. Rapid heartbeat, chest pain, nausea, dizziness, flushing, thirst. So that's something that will usually induce vomiting soon after if someone drinks. And for some folks, that works great. That can be something that will prevent them from using. Others, you know, if someone externally is encouraging them to use that, they can drink on it, vomit, which I know sounds totally disgusting, and then continue drinking, but it happens. Or they can tell whomever, yeah, I'm taking it, and not. The next one then is the naltrexone or the Rivia or Vivitrol, and that's the injection. And that can be 50 milligrams 1 time per day, and it's that intramuscular injection, and that's every 4 weeks. So that gives the high level overview of what's available then for alcohol. You can go to the next one, Christy. And then, so this starts then with the MAT initiation and dosing, and this is where it's a little bit more, there's a little bit more details or meat to this. So with buprenorphine, this can be initiated after the person has abstained from opioids for 24 hours. If this medication is, initiated sooner than that, like I said, they're going to experience those precipitated withdrawal symptoms. They're going to feel really crummy. They're going to question if the medication works. They're going to want a higher dose. So it's really important that you emphasize to the individual, you got to be honest with us when your last use was. Because if we give you this medication and it was less than 24 hours ago, you're going to feel really bad really fast. The primary dose, once someone has been inducted into a Suboxone program, the daily dose is usually around 16 milligrams. Studies have shown that anything beyond 16 milligrams really doesn't have an effect because it, again, kind of like that opioid receptor site, when it's filled with cement, anything that's taken beyond that just kind of overflows. There really isn't any benefit to it. The other piece too is our physicians really stick to the 16 because there's concern that if they go higher, because that opioid receptor site is full, that they may not need the 24 doses and there could be diversion, or the 24 milligrams. So really, based on what I know to be true with our physicians, they don't go beyond 16 milligrams per day. They start someone out on 8 milligrams, they monitor them. That's the other piece that I wanted to share is anytime we do an induction for MAT, the patient is pretty much there for that first day for about 6 hours. They meet with a nurse, they meet with a therapist, they meet with a physician, and then we actually watch them for side effects to get an idea if the medication is helping, to review their symptoms, to review their blood pressure, because there can be, just like anything else, negative side effects for folks. So it's a pretty lengthy process for someone to be inducted into Suboxone and methadone. With methadone, then, methadone can be initiated as soon as symptoms of withdrawal are present. So that could be 12 hours, 24 hours. We just ask that someone, their last use is within the last 12 hours before they come in and do their induction, because that will be the most effective. When someone starts methadone, they're started out at 20 milligrams. And again, they're at the clinic for pretty much the whole day and we watch them. So they're given the 20 milligram dose. They're asked to have a seat in the waiting room where they can go down to the cafeteria and get something to eat and come back up. But we really pay close attention to how they're feeling, side effects, things like that. If they're doing well with that 20 milligram dose and it feels like they're covered, they can leave the clinic. If it feels like they're still experiencing those withdrawal symptoms, we can bump it up to 30 milligrams. Let's say the 30 milligrams really isn't impacting the patient enough to do away with those withdrawal symptoms. We can go up to 40 milligrams, but that is really our cap. We can't go beyond 40 milligrams, and that is something that's federally regulated. We can't go beyond that because there's concern just about physically what that will do to that individual. To my knowledge, it's rare that we have to go up to 40 milligrams. Usually folks feel much better when they get that 20 or 30 milligram dosage on their first day. And then of course, after that, you can go up 5 to 10 milligrams. Beyond that, usually the next day. Again, it's something that's closely monitored though. So the target range for methadone then is between 80 and 100 milligrams. We've certainly had folks transfer into our program that have been above that. Generally, though, we try to stay within that window of 80 to 120 milligrams. Again, because there's concern about diversion if folks have take-home doses, because there's pretty significant street value to Suboxone and methadone. So we really want to keep those doses at a therapeutic dose and not give too much. So the folks that are receiving the methadone, we really watch to get an idea of where they are with withdrawals, how significant those withdrawals are. And then of course, the other thing that I want to call out is with women that are pregnant. A lot of times during pregnancy, because of hormonal changes and things like that, doses need to be increased for folks to experience that same effect that they did before pregnancy. And so what will generally happen is that when a woman is pregnant, we'll increase their dose, usually not by a lot. So I'm talking like 5-10 milligrams. And then after delivery, it'll be reduced. I had a patient not too long ago that we increased her dose during pregnancy. And then after she gave birth, she immediately came in and she's like, whoa, that dose is way too high, way too high. She felt very sedated. The interesting thing with methadone is that I had this belief that if someone was nodding out or not able to just be coherent and continue to talk and make eye contact, I always assumed that it was because their methadone dose was too high. Through training and education, though, I've learned that it can happen both. someone can experience those types of symptoms if their dose is too few, if it's not enough, or if it's too much. So it really takes some work to kind of tease that out and working with the physician. Something that we use to kind of clarify that is called a peak and trough. And so we do screenings at the peak of when that individual gets their medication. And then I believe it's 2 hours later, we do a screening and assessment to see kind of where they are at their baseline. Because we really want to be mindful not to give them too much medication while also still managing those withdrawal symptoms. We can go to the next one. So the next overview that I want to provide, so with both programs, there are phases. The phases really coincide with how long someone has been on the program. So with Suboxone or buprenorphine, we've created the phases up above. So I just wanted to call that out, that those are the Gundersen Health System guidelines. If you were to reach out to any other buprenorphine programs, I'm guessing they would have similar kind of outlines for phasing. This is the one that we've created for our folks, and it really spells out what the requirement is for the patient, how long they need to be in the program, what they need to do for frequency for seeing the physician, their therapy appointments, their weekly random urine drug screens, and then their film counts. So in phase 1, which is that first 90 days, they're seeing their physician on a weekly basis, they're doing weekly therapy, and that can either be in the way of individual therapy or it can be day treatment. And day treatment for us is 3 days a week. It's 12 hours of therapy. There's also weekly random urine drug screens. So someone could get a test on a Monday and then get called back on a Friday. We try to really change that up, especially when someone's new, just to make sure that there aren't other substances in there. And then we also do those film and pill counts. Initially, when buprenorphine kind of came to the forefront, it was in pill form. And folks soon realized that you could melt down the pill and inject it and abuse it. And so the manufacturers switched then from pills to actual strips, because you can't do the same sort of thing with the strips. For anyone who hasn't seen those strips, they really look like those breath mints, very similar. And so when they come in to do those weekly check-ins, we then count their film strips too. So if they were given, let's say I'm just going to use 7, and they've only been on the program for 2 days, we need to make sure that that math adds up with how many they should have. If their count is off, then we have a really frank discussion with them of, so help us understand, why you're missing strips and where did they go and what happened. And if a patient were to say, my car got broken into or my apartment got broken into, to remain on the program, they need to then file a police report because there's concern about diversion. As much as we'd like to take people's, word for it, that it did actually happen, we really need to have them file a police report. If someone is reluctant to file a police report, that's definitely a red flag. Most likely, maybe not always, but most likely indicating that something else is going on. So then following that first 90 days, for the 3 to 6 months, then it's bi-monthly MD appointments. So those MD appointments generally consist of 15-minute check-ins. How are you doing? How are you feeling? Are you taking your meds prescribed? Any withdrawal symptoms? And then continuing with those therapy appointments, and then the bi-weekly random urine drug screens and film counts. The film counts generally occur with our medical assistant or our RN. So the client really has a lot of involvement with a variety of folks in our department just to make sure that they're feeling supported and being held accountable for that program. And then beyond that, so going into phase 4 and 5, then we lessen up the frequency of when they need to see their physician. We really want folks to stay involved in therapy services for that first year. Not to say that they need to be seen for individual therapy every week for a year, but involved in some type of therapy service, even if it's, once every 2 months. If they've completed a primary care program and they're now being seen for individual, we really want them involved in therapy services at least for that first year. Ideally, also, they have, supports in the community that are supporting their recovery, whether it be Smart Recovery or Mutual Support Program, 12 steps, something like that. Again, it's not required, but we strongly encourage it. And with buprenorphine too, when I got into the field, this even happens still now. there's that school of thought that medication-assisted treatment can be a time-limited thing, where I've had some prescribers that'll say, I'll offer it for 2 years, and then I'm going to start working with the patient to taper. I've had other prescribers that'll say, I leave it up to the patient. If the patient feels in a year that they want to taper and start working on their recovery without MAT, that's fine. And I've had others that'll say, if the patient wants to stay on it for their lifetime, I will continue to support it for their lifetime. Initially, when I came into the field, I had a belief that it should be time limited, and I still kind of go back and forth on that. But ultimately, I want what's best for the patient. I want them to pursue whatever they feel like they need to support their recovery. Similar with methadone, like I shared, I have a patient that I see that's on the methadone program. He's been on the methadone program for 15 years. He's doing really well. I see him every 3 months for therapy. It's more so of a check-in, and really more so now to support his mental health, addressing social anxiety, family of origin stuff. I feel like he's doing really well with his substance use disorder. So now we're addressing other things. And to be honest, sometimes it is more superficial check-in because it is a requirement, but he does verbalize that he gets benefit from coming in. So with the methadone program, similar to the buprenorphine, there are phases. With these phases, then, it's a little bit more stringent, like I had said before, because of the take-home doses. With buprenorphine, when someone starts, they can be given 6 take-homes during their first week. Then, of course, we have those scripts counted and things when they come back in. With dosing with methadone, their first 90 days, they're allowed 1 unsupervised dose per week, and that's generally a Sunday. So those first 90 days, they get 1 take-home dose. So 6 days a week for those first 90 days, they're coming into the clinic for dosing. So that's something we really call out from the front end, because not everyone has the ability, transportation, has leniency with work to be able to leave and come to the clinic 6 days a week for 90 days. So we very much share that on the front end. Look, these are the things that you're going to have to adhere to. If you can do this, great, we want to support you. We just want to call this up from the front end, though, the obligation of being part of this program and what that would entail. So moving into phase 2, then, they'll receive 2 unsupervised doses. And again, it's usually a Sunday dose. And they're also required to see a physician, to see a therapist. And it's really determined by the therapist how often they need to be seen. For some folks, it is once a week. For others, they need residential. And so we get them admitted to residential, and then we do their dosing while they're at the residential facility. They come over to the methadone clinic to dose and then go back to the residential facility. So similar holds true then with phases 3, 4, and 5, and 6. With these phases, then, this is something that we talk about on a weekly basis with our patients, or about our patients that are on this program, especially with the methadone, because they can request increases in their dose and increases in take-homes, and that's discussed with the team and approved by the team. If there are concerns with diversion, or let's say someone has been showing up late for dosing, they've missed appointments, they haven't completed urine drug screens, that certainly impacts whether they can get additional take-homes or increase a dose. So those sort of things, anytime a patient requests a phase increase, we look at all of those things. Are they doing what they need to do for that program or recovery? If they're taking their medication as prescribed, they're coming in for dosing, but they're not seeing anyone for therapy, that's going to prohibit them from moving up in a phase. And so there's very much that accountability of, if you're not doing those things, you're not then going to get additional take-homes. You're not going to have that leniency then. So for a lot of folks, that's that carrot that we dangle in front of them. And we, for certain, anyone that works with human beings, more often than not, dangling that carrot versus having a stick is going to be much more motivating to folks. And so we definitely look at it as that carrot that we're dangling, to try to help support folks and offer them, more freedom and leniency with their program of recovery. And then I just put the little asterisks at the bottom to call out. So with Suboxone, again, we really encourage folks to be involved in therapy services. It's not required, though. Initially, we want them to be involved in therapy services, to address their substance use, to address relapse issues, to call out peer refusal skills. Once they have that foundation, though, they can be discharged, or they can check in with us every 90 days. With methadone, though, the person is required to be in therapy for the duration. So in full transparency, we've certainly had some folks that have been on the program for 2 and 3 years, and because that is a requirement and they want additional freedom, they've said, I think I want to switch from methadone to Suboxone because I can have those additional take homes. There isn't the requirement of therapy. And so our physicians, of course, then transition them from methadone to buprenorphine because we realize there's additional freedom that goes along with that. I recently had a patient that is part of our methadone program, and she was traveling with family out to Maine. And I believe she had 2 take-home doses. So she was still having to come to the clinic 5 days a week. So in order for her to travel, I needed to reach out to, she was traveling in Maine. I had to reach out to a few methadone clinics out in Maine to be able to get her, it's called guest dosing, for her to be able to dose at another clinic. So I certainly understand why for some folks remaining on a methadone program isn't an option because there are those ties that bind you to that dosing clinic. Even if you're on phase 6, if you've been a part of the program for 2 consecutive years and you get 13 unsupervised take homes, there still are requirements that you have to come into the clinic. So methadone isn't for everyone, and we certainly are transparent about that, the requirements that are involved in that, because it's very stringent, especially initially, the frequency that folks need to come into the clinic. We can go to the next slide. And so I want to give an overview of the competency-based orientation for therapists. And it's not so different than, regular interventions that we'd offer for substance use disorders or really any sort of therapy services that we offer. The ones that we focus on predominantly are with, folks that are talking about stages of change, that we give that we do motivational interviewing, we do that enhancement. And along with that training, we have, on a yearly basis, we have a competency-based orientation for our MAT therapists. So anytime a new clinician starts at Gunderson or is new to the methadone program, we have a competency-based orientation that we need to go through. And I just called out 6 of them here. There's about 4 pages worth, but I just wanted to pull out kind of the highlights of that training for them. So before someone really joins that team of providers, they need to have that overview of that program, what the requirements are, what the induction phase looks like, what take homes are offered at which phase. So with this, it's definitely, as a clinical manager, I'm meeting with folks then to go over these. And it's something that we certainly review. I mean, I've been doing this for 6 years. And for a competency-based orientation kind of handouts, there's 6 pages. I can certainly look at that and talk about it. But if someone were to say, hey, give me an overview without looking at it, I would be lost. Same with the 12 steps. I know the majority of them, but I couldn't recall all of them off the top of my head. So when someone's involved in MAT, we have these competency requirements. And this is also reviewed by our state opioid treatment authority when she comes on a yearly basis. This is something that she reviews similar to Joint Commission when they come and do their surveys. And she'll also ask to see these competency-based orientations that they were completed, and she'll also ask my clinicians about them. Not that she wants to trip them up, she wants to make sure that they understand the programming and the program requirements. It can be a bit intense, I'll be completely honest about that. Our clinicians do a great job though. So in order to be a part of that program, the clinician needs to demonstrate that knowledge of opioid treatment, what that consists of, the type of therapies that we offer and when. Because a lot of times those conversations are initiated in that first initial intake assessment with the therapist. Because sometimes we do intake assessments with folks that hadn't even considered the option of medication-assisted treatment. So we're having that discussion about, okay, I hear you, you're motivated for recovery. Have you heard about medication-assisted treatment? If you're interested, I can provide you additional information. And again, I can't emphasize enough that it's not that we push folks towards MAT. It's one tool in a toolbox. I just want to have folks have an overview of what's available. So it's imperative that our clinicians have a good, solid overview of what that consists of. And then our clinicians need to demonstrate verbally. So just talking us through, the induction phase, what the rehab phase looks like, the maintenance phase, and then tapering. Tapering is another significant component of MAT because, again, not everyone wants to stay on MAT for the rest of their lives. So for a tapering process, there really is an outline, an overview of what that looks like. It's very stepwise. And it's usually done in small increments. So for methadone, it's usually done in like 2 to 5 milligram increments when they do decide to taper. And when someone's tapering, that's usually when we increase therapy services as well. Because for some folks, they feel like I've done really well. I've been on this program for 5 years. I kind of have everything that I need. And then they start the taper process, and it can bring up some of that anxiety, because for a lot of folks, being on MAT can kind of be like a security blanket. It's in the back of their mind that if they have thoughts about it, that it can help manage the urges and cravings. If they decide to use, it's not going to have the same impact. There isn't that concern about overdose. So that's something that we really work closely with folks that are tapering, because, again, we want them to be supported. We don't want to say, okay, we're going to taper you 2 milligrams each day. Let us know how you're doing. That's usually when we actually increase therapy services, when someone is looking to taper, because we want to support them throughout that kind of step down process. The other piece then is understanding how to support your patient with urine drug screens. Urine drug screens are something, of course, that the physician orders. We as therapists, though, can order them as well, as long as there's a standing order in the system from the physician. So just understanding that process. And there are certainly times where the physician may not have current concerns about the patient, because the physician may only see them every 90 days. With us as therapists seeing them more often, though, we might pick up on something that's kind of concerning or off for the patient. So we have the ability as therapists to request a urine drug screen or to request a breathalyzer test before they leave. So it's imperative that the clinicians know that they have the ability to do that, how to do that, when it's appropriate to do that, and how to explain that to the patients. And then, of course, there's the documentation. Within Gundersen Health System, we use Epic. So just knowing how and where to document those things in Epic, how to put orders in. And then there's the piece about referral. The majority of our folks, our clinicians, are duly credentialed, mental health and substance use disorder trained. We do have a handful of providers that are bachelor's level providers, that have an undergrad certification in substance use disorders, or maybe they have a bachelor's degree in psychology or sociology. So folks that don't have that training, they need to be familiar with how to make those referrals to other folks that have that training, that can provide that treatment for folks. Like I said, the majority of our folks that are involved in the MAT programming are duly credentialed, which is really helpful, because then it's one therapist for both mental health and substance use disorders. And the other important piece then, and I feel like this is a focal point of really any organization, mental health organization across the globe, is that being trauma-informed care aware, having that training on a yearly basis. We have folks that will come in and do training. We have online training, because for anyone that works with folks with substance use disorders, it feels like 99.9% of them have some sort of trauma. Because let's be honest, nobody wakes up on a Tuesday and says, today, I think the right thing to do is be an addict. There are so many things that go into that cause substance use disorders. For so many folks, it's trauma, that it was trauma in childhood, that it was continual trauma from childhood through adulthood. So really being aware of that, knowing how to treat, knowing how to assess, knowing how to treat. And if you're not able to treat, knowing who to refer that person to, because that commonality between trauma and substance use disorders seems like it's nearly with everyone. I can't think right now anyone that I've treated with substance use disorder that hasn't either had some co-occurring disorder, whether it be anxiety, depression, bipolar, along with trauma. It feels like the majority have some type of trauma associated, and that's kind of what prompted them to begin using substances in the first place. So really addressing that is part of that therapy for MAT. And we can go on. So this just gives an overview then of the psychotherapy for medication-assisted treatment. So I shared that our 3 addictionologists really have significant involvement with therapy services. In the places that I've worked historically, and even that I know in the community, there isn't a whole lot of physician involvement with therapy services. So Gundersen is kind of unique in the way that we have our 3 prescribers that actually facilitate group therapy too, which is pretty cool. And 2 of our prescribers, and they're open about this, they're also in recovery themselves. And so they talk about their experience in recovery and what it was like and how they got into recovery and kind of stumbling blocks for them. So I think it's really helpful for the patients to see that side too. So the medical psychotherapy that's generally offered outside of those weekly groups that our addictionologists offer is really about that brief education. Are they adhering to their medications? What goals do they have for themselves? And then 2 of our addictionologists are very heavily focused on 12-step. Being in recovery themselves, they feel very strongly about that. And again, not that it's required, but it's something that's strongly encouraged. And those appointments with the physicians are usually between 15 and 20 minutes, unless it's an intake assessment. And then that's usually about 90 minutes. And then the next one is the general substance use disorder therapy. So with that, it can be in the form of individual therapy, group therapy. Of course, we talk about triggers, craving management, coping with guilt, shame, those peer refusal skills that's hugely important, relationship management, that emotional regulation piece. And with that, a lot of times there's some DBT that's infused in there with that emotional regulation. And then the 12-step participation is encouraged. We talk about the disease model. And I know one of our addictionologists, Dr. Kelly, spends a lot of time talking about spiritual recovery and how important that is. So that's definitely something that we talk about in individual therapy and in group therapy. And then, of course, kind of the common cognitive behavioral therapy, talking about the consequences of use. When you were using, what occurred, what consequences did you experience? And then that cognitive restructuring along with that skills management. How are your thoughts impacting your behaviors? How can we manage those thoughts so that they're not impacting your behaviors no longer in a negative way? How can we reframe things and look at them from a different way? And then the other piece that I talked about was the contingency management. So that's in the way of kind of the phases that we have for medication-assisted treatment, especially with methadone, that, an individual can, based on their time in the program and how well they're adhering to the requirements, can receive additional take-homes, can have that additional freedom. Similar to Suboxone, I think it's more emphasized, though, with the methadone program, where we have that carrot, so to speak, there. I've also, though, used contingency management with folks that I'm seeing in group therapy. If I have someone that's really struggling with attendance, I will say, if you make this next week, I'm able to get a voucher, like a gas card or something like that. I've used that historically too, kind of as that carrot to dangle to increase the adherence and, just attendance and things like that. I don't know if anyone else has had success with that. I know that that's something that, probably about 5 years ago, I was involved in La Crosse County OWI treatment court. And my background is, my undergrad was in psychology and criminal justice. And so when I initially thought about joining the OWI treatment court team, I very much had that mindset of criminal justice. And so I went in there thinking that it was going to be very punitive. And much to my surprise, it was the complete opposite of that. It very much was supportive. It very much was highlighting how the folks are doing well, congratulating them for that. If someone had made their meetings, maintain abstinence, they were able to kind of pull, a gift card or some sort of treat from, kind of this little box that they had. And then when someone achieved like milestone recovery moments, like for 30 days, 60 days, the whole courtroom would like break out in clapping, which totally blew my mind initially. I remember standing there and there were probably 50 of us in the courtroom and someone had just achieved, I think it was their year of sobriety, and everyone just started clapping. And I remember kind of looking around like, what is going on? Because my background being in criminal justice, again, that mindset was more of that punitive. And so it was really refreshing to see that kind of support being offered, because that's not how I thought it would be. So since then, I've been even more of a huge fan of that contingency management of, catching them doing something well versus catching them and saying, you're doing that wrong and we got to work on this. Catch them doing something right and give them kudos for that. It can make a huge difference. And then, of course, that motivational enhancement. When I worked at Hiawatha Valley, a lot of us became trained in motivational interviewing. And I'm sure many of you have taken classes in motivational interviewing. And before I was trained in motivational interviewing, I definitely focused more on CBT, which is great. It's a great foundation. After being trained in motivational interviewing, though, I felt better equipped to work with folks with substance use disorders because it allowed me to meet them where they're at. It felt like it was less confrontational. I wasn't arguing back and forth why recovery was the right thing to do. It allowed me to feel more comfortable with the patient as saying, help me understand how that works for you. And also, if this is your goal, how do we get there? How does your behavior that you're demonstrating, how is that incongruent with the goals that you want to achieve? Because I was initially trained by folks that were very kind of in your face, for lack of a better way to describe it. Come back to me when you're ready to be sober, and, don't you dare call me if you're still using. And motivational interviewing really put a different spin on that. It was very much supportive. And if you're struggling, I want to know about it, because if I don't know, I can't help you. So I heavily still rely on motivational interviewing, especially with the folks that are really kind of on that fence of, pre-contemplation, contemplation. I'm meeting you where you're at. What can I do to help support you where you're at in this moment? And really highlighting those successes. When we use those scaling questions on a scale from 0 to 10, where are your urges today? And 10 being significant and 0 being none. If someone says 6, I'm not going to go, well, why are you a 6 and not an 8? Instead, I'm going to go, okay, so what makes you a 4? Or what makes you a 6 instead of a 4? Because I want to highlight the benefit of them being at a 6 versus a 4. So again, I cannot say enough good things about motivational interviewing. It's just been something that's really helped me as a clinician provide services for folks with substance use disorders. And then another integral part is that family therapy, because again, addiction is a family disease. If you think of a child's mobile that hangs over a crib, if you touch any part of that, the whole thing moves. Think about that as the family dynamics, that if one person is struggling either with mental illness or a substance use disorder, everyone is struggling to some degree. And so there needs to be, for a lot of folks, that family involvement, that family therapy. And that's something that we really try. Of course, we're not successful with everyone to bring everyone's significant other or family member in, but we certainly do ask that we get support of their significant other or a friend or any colleague, someone that can be supportive of their recovery, that we involve them in therapy services. And you can go to the next. And then this just gives an overview of group therapy services that are frequently offered for folks involved in medication-assisted treatment. So I had referenced that we offer substance use disorder day treatment. That is considered an ASAM level 2 treatment, if you all are familiar, which I believe you are, with ASAM level of care. That group meets 4 times a week for 3 hours a day. So it's 12 hours a week, 12 hours a group. And then as part of that level of care, the individual is also required to be seen for 1 individual therapy session a week. So they have the 12 hours a group and then the 1 individual session. With that level of care, our clinicians, we have a group in La Crosse, Alaska, and the focal point for that level of care, they use the matrix model. I'm sure some of you have heard of the matrix model. It originally came out as an intervention specifically for stimulant use disorder. It does work really well, though, for other types of substances. And I mean, especially at the onset of this, I shared that a lot of the referrals that we get in, folks are using meth or other types of stimulants. So for our substance use disorder day treatment, it's very much CBT. We use the matrix model, which is very manualized. So each of the individuals have, a binder. There's specific outlines of topics that we go over, and both of the providers really try to involve family in those individual sessions too, if the family is available and willing to be part of those sessions. And then with that matrix model, the therapist definitely, and I'm sure with most models, you're functioning as the teacher, as the coach, as the cheerleader. Sometimes too, you're taking on that role as the parent, because a lot of our folks, they didn't have a strong parent in their lives. So for some folks, it kind of feels like we're reparenting and teaching them those things that they didn't learn in childhood. So we provide that in a group setting, more so in an individual setting, because everyone kind of has different needs. But we really focus on that self-esteem, that dignity, building self-worth, self-esteem, And then our providers are duly credentialed with those programs too. So there also are components of mental health along with that substance use in there too, because so many of our folks are duly diagnosed. And then after folks complete that primary care of treatment, that day treatment, they're in there usually between 8 and 12 weeks. It very much is individualized depending on where kind of the patient is at. Following completion of that, then the majority of folks, we like to transition them down to a weekly relapse prevention group. And so that's 1 time per week, and it's 2 hours. And again, not that folks have to go into that level of care, but we really want to provide that ongoing support, especially for that first year. So providing a lot of different supports is imperative. I know when I worked at Hiawatha Valley, I believe we had like an evening IOP group and there were relapse prevention groups. And so I'm sure you guys are doing similar, which is great because having those different levels of care is imperative for our folks to support them. And then we can go on to the next, which I believe is the last one. How am I doing on time? Got a half hour, which is awesome. So I want to, in the half hour that we have left, does anyone have questions? I certainly want to take time because I went over a lot of stuff in 90 minutes. So I certainly want to open the floor if anyone has questions, anything I can clarify. I'm absolutely open to that. Or is everyone going to be quiet because y'all want to go to lunch?
I've got a question for you.
Yeah,
Are there any plans to bring any of these services to your Winona Gunderson facility?
That is such a good question. So let's see, when the Winona Clinic opened, was it about 2 or 3 years ago? I think it might have been 3 years ago. So when the Winona Clinic opened, we actually begged to have a strong behavioral health presence in Winona. And at that time we were told, no, I'm sorry, it's not an option because space was an issue. We have a behavioral health consultant out there embedded within Family Med. I would really like for us to have more of a presence in Winona though too. So it's definitely something that I've been putting a bug in the ear of my administrative director. It sounds like right now that space is the limitation, but at some point soon, I would absolutely love to. Yes. I wish I had a better answer for you.
Yeah, I mean, to bolster your request for that, I can provide you with some mapping that we recently did as a community, which would indicate that there is a need.
I would absolutely welcome that.
Especially for medication-assisted treatment.
I would love for you to send me whatever you have because I'm not a numbers person. That's why I became a therapist. So I'm like, this is the feelings why I need this. So if you can provide me like numbers to support that, that would be fantastic. Any other questions from folks? And again, I've given the PowerPoint to Christy. Christy, you have my contact information too. So I know for some folks, like you may not have any questions right now, but something may come up after. So Christy can give you my contact information. Feel free to give me a call. Feel free to shoot me an email, whatever works.
All right. Well, if anybody has any questions that they think of afterwards, like Mandy said, just shoot them to me, or when I send out you the PowerPoint later today, you will have Mandy's contact information. So there are no questions right now. I guess we get to head to lunch a little bit early.
Awesome. Thanks, everyone. I really appreciate you inviting me, and it was good talking to you all.
Yes. Thank you so much, Mandy.
For sure. Take care,
Bye,
everyone.
everyone.
Have a good day.
Bye.